We're going to go with item C, and we have Alex Briscoe here from Alameda County.
Thanks. Good evening. So I'm from the background of mental health, and a mentor once said to me, human beings have the most complicated descriptions for the things they understand the least. So in 10 or 12 minutes, I'm going to take you through the 1,200 pages of the Affordable Care Act, and I'm going to distill it so you understand it. So buckle down. Everything I'm giving you is in multiple places that I'm going to show you, and my colleague Lisa Forte is going to come after me to get into some of the details of enrollment eligibility. So stick with me. I'm going to move fast. You're in Alameda County, 5% of the state. It's essential to understand that counties in California play the role that states play throughout the rest of the nation. The state and federal dollar devolve to the county health authority before they become a contract for service. So all of the Medi-Cal funded services in your special education classrooms are written through contracts through our organization. So understanding the role of the county is essential. So that's us, that little red thing. And we happen to be one of the most diverse counties in the nation by ethnic plurality. And before I even get into the 1,200 pages of the Act, what we say in our public health department is tell us what zip code you live in and we'll tell you how long you're going to live. So I'm going to take you through health policy more than you could ever absorb in my 12 minutes, but I need to lead off with a really harsh truth that's designed to make you uncomfortable, which health actually isn't about health insurance. In fact, and again, this is meant to make you uncomfortable, despite the gains of the civil rights movement in Alameda County, these are birth and death records from Alameda County, African Americans in 1960 lived 4 years less than their white counterparts. By 2009, that had grown to 6.5 years. Today, it's 7.3 years. So despite the legal gains of the civil rights movement, African Americans are living shorter in Alameda County, significantly, almost twice as short as they did in 1960. So as I get into healthcare and delivery system and health insurance and all of the rules, remember that actually what makes someone healthy is a sense of meaning and belonging, a good job, a safe community to live in, good schools to send their kids to. So no amount of clinics are going to treat away what's making us sick. That's actually poverty and race and class. So if you took the $1 billion that we direct or spend a year and put $1 for every dot on the map, the places where we spend the most money are the places where healthcare disparities have persisted the longest. So with that, not to be preachy, this breaks down by infants, children, and adults. This is public health data. It's cumulative 15-year impact of difference between white Alameda County residents who live in the Oakland Hills and African Americans who live in 94608. To the uninsured, this plays out in uninsurance, of course, because, frankly, poverty is more stable now than any point in the history of America. And since 2008 and today, nothing good has happened to poor people, right? It's one of the deepest economic recessions since the Great Depression. The number of uninsured rose from 166,000 to 200,000 during that period of time. And when you break that down by city, because remember, place matters, these are all the cities in Alameda County with more than 20,000 residents. You're not actually on here, because you got less than 20,000 folks. But I'll show you some data in a second which show you where you lie. But frankly, you'll see here that Hayward, Oakland, and the unincorporated areas, 1 in 5 or 1 in 4 residents are uninsured. And this is complicit with poverty, right? Because in the great American tradition, you can show at any one of our 911 receiving centers. EMTALA protects you. We can't turn you away, but we can charge the heck out of you. 1 in 4 bankruptcies in Alameda County are driven by medical debt. So we're perpetuating poverty by this lack of insurance, which forces you to the emergency department. We create a bill, you go into bankruptcy. Of the uninsured, the vast majority are single adults, right? Of the 200,000, about 20,000 are children. But remember, of the 20,000 uninsured children, 14,000 are eligible but not enrolled today. So hold back, because it's going to come back. But the remainder is this weird ethical and moral failure of the American civilization, right? If you were born after 1965, raise your hand. Good. Okay, thank you. 1965. In 1965, Medicaid and Medicare were created, Title 19, right? And we were the only industrialized, and have been since that time, the only industrialized nation in the world that offered no medical safety net, right? So Medicaid for poor people, to get it, you had to be a kid in poor, right? Because it's okay to be poor if you're a kid, right? But if you were 19 to 64, you had to be poor with a dependent child or disabled to get Medicaid. So this medically indigent adult, 25, 30 million folks in America never qualified for anything. And you see that reflected in our numbers, right? Those adults 19 to 64. One thing the Affordable Care Act does is close that hole. It now says everyone 0 to 64 under 138% of federal poverty or making less than about 16 grand a year now gets Medicaid. It's a good thing. But lest you think that's the uninsured, one of the great myths of the uninsured is that they're mostly poor people. It's not true. The vast majority of the uninsured are the working poor, people with 1, 2, or 3 jobs who can't afford to purchase health insurance or whose employer doesn't offer it. And when I show you in a second, while we're really glad that 50-some thousand people are going to get Medicaid, twice as many are going to be forced to purchase commercial insurance, either through their employer or through this private thing called the exchange. Don't believe the hype. It was signed in March 2010. In fact, you're in ground zero for health reform. This jurisdiction, Alameda County, has done more under the Affordable Care Act than any other public jurisdiction. Over 90% of those who will be eligible for Medicaid are already enrolled through something called our low-income health program. It's a big thing. Okay. It's the most sweeping legislation for those of us born after 1965. It's going to add 16 million Americans. It's going to create an individual mandate. You have to have health insurance like you have to have car insurance. 22% of American drivers drive uninsured. So there's kinds of all sorts of problems, right? But it's the law. And I'm going to move quick. It includes these things around coverage expansion. You have to have it, right? An individual mandate. Your employer has to offer it if you have more than 50 employees. And it creates this new pooling mechanism for the uninsured to mass buy through this thing called the healthcare exchange. There's also big insurance market reform, and I can be pretty jaded on this stuff, so I need to be careful, okay? On one level, it's great, right? We said no lifetime caps. You can't kick someone out after they spend $1 million. Good thing, right? You can't deny someone based on a pre-existing condition. Good thing. You can carry your kids through the age of 26. Good thing. These are all curbing the most egregious excesses of the private insurance industry. I would argue, small price to pay for a law that you have to buy my product. Okay? So lest we be careful, the Affordable Care Act will be the single largest act of corporate welfare in the history of America. We have to watch it like a hawk. Or those who shamelessly profit on human illness and suffering will win. And right now, we're not winning, right? The safety net funding changes, so those clinics that you rely on, Lifelong, Access, Tri-City, those clinics, their funding changes, so it's really important that we protect the safety net as it rolls out. So what does it mean? I'm going to ask you to suspend disbelief for a second and say everyone got what they should, even though we know that doesn't happen, right? But let's pretend everyone got what they should. It would be, of the 1.5 million people here, we think there's about 229,000 uninsured folks. Assuming full implementation, and I do my job, and Lisa Shop does their job, and we do what we're paid to do, despite all the challenges, 227 million would come into the county for 56,000 folks. I'll show you this on a graphic in a second. I know there's a lot of words. And another 107,000 folks would get covered, bringing another 370 million in. So as I was talking to Lisa before, about 600 or 700 million in new money, in new federal match coming into Alameda County. We have to ensure some of that lands in the hands of poor people so they can get access to family-sustaining employment, because that's what's going to matter more to them than health insurance, right? After full enrollment, we'll be at about 95%. Now this can be done, right? Massachusetts hit 98%. But the reason it's 95% in Alameda County, and I'm really proud to work here for this reason, there's only a handful of counties that I could work in. We offer health insurance in Alameda County, or health coverage, regardless of immigration status. The Alameda County Board of Supervisors has done so over at $100 million a year since 1970-something or other. And we say it's a basic human right, that it can't be denied and should not be denied. But what that means is no one who's not an American citizen qualifies under the Affordable Care Act because of the Deficit Reduction Act. So you can't spend any federal money on people who can't prove they're a citizen. That's 60,000 Alameda County residents that we have to continue to serve. So this is just a graphic. On the left-hand side, 0 to 138 is 56,000, 107,000 between 138 and 400, and that's where it caps. So I know these are numbers, but think about 0 to 15 or 16,000 a year, you get it free. 16,000 to 40 or 50,000, you get some help to buy. And that some help to buy is you kind of sign on to an eBay for health insurance, called this thing called the California Health Exchange, and you sell your wares there, and you buy it, right? Now, we're also very proud to say that only one county has its public plan for available on the exchange. It's actually 2 now. 2 public plans are available for purchase on the exchange. We're one of them, the Alameda Alliance. It's a good plan, better than Blue Cross. 110,000 enrollees. We're doing great. And this is our sort of ground-up way to build a public option. And so I'm going to just, I'm going to skip bragging about how good we've been on the pre-adoption. We've done real good. We've done more than any county in the state. We've pre-enrolled lots of folks. Almost 90,000 people, 45,000 will convert. We far exceed any other county. We brought in $50 million a year of new revenue. We're really proud of it. But it was mostly just a kind of launch, a stepping stone to the real thing, which starts in January. This map shows you, and this actually has some data behind it, I'll leave it for you, which shows that Emeryville in the upper left-hand corner actually has that dichotomy of some communities, 94608, with intense need, massive uninsurance rates, and some with huge employer-based coverage rates. But our challenge is eligibility doesn't mean enrollment, enrollment doesn't mean access, and access doesn't mean good outcomes, right? And these are the challenges and the opportunities of the Affordable Care Act. And I'm skipping because I want to do some quick things on the delivery system just to show you how it works. And I've just got 2 minutes left. As I said, we're unaffordable for 200,000. Medical debt is the leading cause of financial ruin. Our healthcare services are fragmented. And at the heart of this thing is, and with all due respect to the previous speaker, you don't need a hospital, right? We don't want any more hospitals. Hospitals cost a lot of money, and you go there to die. It's bad. We have an incredible technology in Western culture. It's called primary and preventative care. We just don't have enough of it. We're not training enough docs. My wife is a primary and preventative care pediatrician. She graduated in a class of 142 from UCSF. 4 doctors went into primary care. She made less than the nurse practitioner she supervised her last year of residency. So there's not enough of it. We're not building enough of it. We've got to create new points of access for primary and preventative care and stop this drive of utilization to the highest cost settings. Wait times for primary care as long as 3 months, and this is in one of the most progressive systems in the state, right? So you as commercially insured folks, your plan requires that you get access to primary care within 7 to 10 days. But in the safety net, you can wait 10 to 12 weeks to get a new appointment. So now we wag our finger at poor people and say, don't go to use the emergency room, but where are you supposed to go again? These are the hospitals in Alameda County. Remember, the Public Health Authority runs your 911 system. Alameda County residents are enjoying the fastest 911 response times in the state at the lowest cost. New provider. We didn't pick the purple and teal ambulance colors. That was them. This is a list, all of our primary care sites. Again, I'll leave this PowerPoint for you. If you motion over it, it tells you the address and how to call them. And there's also a website we sponsored with social service agencies called AC Healthcare. And I'm going to end with just an offer of hope, because I've given you, I think, some sense of the challenge that our system faces. We're going to put a whole bunch of people into this private sector model called health insurance, which is a little twisted, right? Kind of a business model that says, say no to make money, right? So we've got a problem. We railed against the excesses of the HMOs, and then we made it the law you have to have that product. So it's weird, okay? So a lot of us believe in a different kind of healthcare system, which is a basic human right, and you build access out. So if you can get access to care, everything else should flow from the premise of getting access. And Alameda County, and you are joining us in this experiment, has done this extraordinary thing, and it began in 1996 with 4 small school-based clinics. And it grew quickly to 8 in 2000, 12 in 2004, 14 in 2008, 19 in 2010, 26 in 2012, and I think you guys, actually we're going to be at 28 at the end of this year, and I think you guys at the new center you're building are going to be 29.
2015.
29, yeah. And this is a basic premise. We took this lemon, right, which was increasing concentration of poverty in public education, right, and we turned it into a lemonade by billing Medicaid for it and creating a new access to a new enhancement and stopping this weird treadmill of asking principals and teachers to be therapists and doctors. They aren't that. They're incredible, but they need to focus on the instructional experience and bring in folks who do this for a living to treat the needs of young people, and Medicaid will pay for it. So we're doing this a lot, and it launched a broader analysis. This is your current healthcare system. This is your general acute care hospital. That's a 911 receiving center, 14 of them. I showed you the map. This is all the primary care we can pay for. If you want to offer primary care, call me. We'll pay you. We just don't have enough of it. We had all of our 911 receiving centers start urgent care clinics, and we now believe that the school-based health centers have taught us about a new level of care, which is what we call portals. They're schools. We've opened 4 new community college clinics, City College of Berkeley, College of Alameda, Laney, soon to be a 4th I can't remember. We want to start them in fire stations. We have our first one we want to launch in Hayward, because remember, firefighters, 85% of what they now do is 911 EMS, right? They're going on every 911 call. And we've done 3 new ones in day labor centers to try to reduce the cost of the undocumented. Finally, this is a website, before I hand it over to Lisa, who's going to have the less sexy thing to talk about, which is how to get in and get through all the rules and regulations, but it's absolutely essential. What I would say as I pass it off, this website at achhealthcare.org is available to anyone. You can type what you need, and it'll give you access within 2, 1, 3, 5 mile radiuses. It'll give you all the information you need. But I would like to invite all of us into understanding the rules, because we're all eligibility and enrollment technicians. We all have to help build a culture of healthcare coverage that does not currently exist. Lisa.
Thank you, Alex. Thanks. He also does IT support. So thank you. That was really inspiring, and it's great to have that framing on the broad implications of the Affordable Care Act. And what I'm going to walk you through is less sexy, but it's the important nuts and bolts that people need to know about what coverage is going to look like and how people are going to get into the system in terms of eligibility and enrollment, starting in October and then especially hitting the ground running in 2014. So starting in 2014, there's going to be these kind of 3 ways that people will get health insurance. And if you haven't seen it, there's this great 7-minute video that the Kaiser Family Foundation put out that explains with a cartoon what the Affordable Care Act is and how people are going to access care. I couldn't take 7 minutes of my 10-minute presentation tonight to show you, but I suggest you go online and check it out if you haven't, because I think it's a great explanation. But essentially, you're going to be able to get coverage through your employer, through government, or through buying your own. And what I'm going to talk about tonight are the boldface ones, which is Medi-Cal in California, which is the federal Medicaid program, and the exchange, which is Covered California, and that's the online market. That's the marketplace that Alex referred to. So first is Medi-Cal, and this was a true challenge. I distilled Medi-Cal into one slide. So Medi-Cal expansion, as Alex said, it closes this hole of the eligible adults, 19 to 64. What it also does is makes people who were barely eligible before or ineligible, it raises the income cap by eliminating this asset test. So whereas before it was 133% of poverty, now it's 138% of poverty. That matters a lot when you think about family wealth building and assets, because we were discouraging people from saving money to work their way out of poverty before. And this is one more step at chipping away at those really archaic laws that disincentivize people and keep them in poverty. So the new eligibility rules are going to make it a little bit simpler. They're going to use a federal income test to help determine your eligibility. So what we have is a whole new population of eligible people, and then for everybody else, your income determination is a little bit different. Actually, not for everybody else. The last section on my slide says not for all. There's still some, I mean, they had to keep it a little bit complicated, or a lot complicated. There are still some special populations where if you're linked to a program, for example, if you're on CalWORKS, you're already on Medi-Cal. So they didn't eliminate the asset test, although we hope they do that someday for CalWORKS. They haven't done it yet. So there's some places where there's still an asset test that applies. But essentially for everybody else, there's a newly eligible population, and there are these simplified income and asset rules, okay? Covered California, that Alex started to describe, is this marketplace for health insurance. And I appreciate the eBay analogy, but I like Consumer Reports better, because I think that the idea is that they're going to help you, like the same way if you go on Consumer Reports and you're shopping for a toaster and you can compare different toasters and like, I like the timer feature, I like the oven feature, whatever the features are, and you can compare the costs. The idea is that Covered California gives you some of that analysis and ability to compare features of plans and costs so that you can make a really educated guess about the type of plans that are available. They have an online portal that's called CalHears, so I'm going to tell you a little bit more in a few minutes about ways that people can get into insurance. CalHears is this online portal that will do that income determination through the federal matching databases, but that's the computer and the internet site is one way that people can get in, and CalHears is the technology that all of the public systems are currently trying to interface with so that we can make sure they talk to each other in the back end. So CalHears is important to know about. The state call centers are, so there's 3 state call centers that have been established. They are supposed to be answering calls from anywhere in the state. They are helping people primarily to enroll in exchange-based coverage. So if you're above 138% of poverty and you're eligible for exchange-based programs and subsidies, the call centers can enroll you in the Covered California plans, like I want the silver or the gold plan. If you are likely eligible for Medi-Cal, that is where my agency comes in. I'm with the Social Services Agency, and the call centers will route people through to social services to complete enrollment. In the state of California, social services staff have to be the ones that do final eligibility determination and enrollment in Medi-Cal. So the way that it works is that there's supposed to be a warm handoff, and my analogy for this one is the AT&T customer service center. So if you call because your phone isn't working, but somebody is answering you who can only talk about your bill, they'll say, hold on, let me get somebody at tech support. They'll wait until they've got John at tech support on the phone, and they'll say, Lisa, I've got John here to help you. I'm going to hang up, and he's going to help you with your phone, right? So that's the idea of what it's supposed to work like between the Covered California call centers and the counties for people who are likely eligible for Medi-Cal. And then there are going to be these things called certified enrollment entities, and these are your community-based organizations. These are, right now there's actually a process where you can go on the Covered California website and apply to be a certified enrollment entity. There will be counselors within these entities who help people enroll in exchange-based programs. I'll tell you a little bit more about how they're incentivizing that, but that's one thing to know, is that there's this potential for an in-person community-based experience. So Gabriella Tunzi, who's our healthcare reform fellow at Social Services, just handed out a sheet that we put together with Healthcare Services and the Interagency Children's Policy Council that I hope you'll find helpful. I think it's a really useful sheet, and hopefully raise your hand if you didn't get one, and Gabriella can make sure you have it. But essentially, we've broken down for different populations and income levels what you're likely going to be eligible for. This is simplified, so it looks complicated, but it's more simple than the real world. But the idea is trying to lay out for people whether or not you'll likely be eligible for the county's indigent care program that Alex spoke about, Medi-Cal, or one of the Covered California programs. And then there's other programs. And then on the back, there's information about who to contact to enroll. So I think that this is a really great cheat sheet. We're going to be starting, tonight's the first night we've publicly handed it out. Actually, Gabriella finished it a few hours ago. So we're starting to disseminate this. So if this is the kind of information that you think would be helpful for the folks that you work with in the schools, let us know. But I think it's just important to see, I think that if I was working in a school district, one of the most important things I want to know is that you're going to have mixed families. So you're going to have families, as Alex mentioned, we have a lot of undocumented immigrants in Alameda County. So you're going to have families that have mixed status in terms of their insurance coverage. So it's just something to really note and make sure that the kids might be eligible for one thing and the parents eligible for another. So that's going to be a complicated issue that we in the enrollment and eligibility world have to work out, but that you as community and family supports should be aware of as well. Okay, so who will help me? So there are these different ways to enter into the system. I mentioned the Covered California Call Center and the warm handoff. There's a certified enrollment entities who can be based in the community. The Social Services Agency will do the Medi-Cal determination. And one thing to note is, just like Covered California has to refer people to Medi-Cal, if people come into the Social Services Agency and they're not eligible for Medi-Cal, we then have to refer them to an exchange-based program. So the idea is that you don't ever come in somewhere and somebody's like, sorry, I can't help you. I don't know what you're supposed to do. They have to help you figure out what coverage is right for you and connect you with that coverage. I also want to at this time just mention that we do have community-based outreach strategies, and actually right now Kauchoy Seichow, who's here, is our Medi-Cal outreach manager and has been working with Juliet Dunn in your Family Resource Center and actually have Medi-Cal outreach staff at the Emeryville Family Resource Center doing that eligibility determination. Those folks can also do CalFresh determination. One of the things that we're really interested in as an agency is making sure that we use healthcare reform as an opportunity to enroll families in all of the benefits that they're eligible for. So CalFresh is a big one because they align in terms of the eligibility very closely. So Kauchoy is here to answer any questions and is representing the great work that our outreach staff does. We're interested in expanding that work as an agency. We're interested in doing more community-based partnerships because we're going to have all hands on deck to make sure that as many families can get enrolled as possible. So these are the two ways that the Covered California, the exchange, is making it possible for community-based organizations to be involved in enrollment and eligibility. And you may have already heard about these, or people are asking you questions, but I wanted to just provide you some context. The certified enrollment entities are what I spoke about before. They'll be actually helping to do applications. So these folks are getting compensated $58 per application to enroll someone in exchange-based coverage. Now, to us, that sounds like a disincentive to enroll low-income families in Medi-Cal and in other coverage that they might be eligible for. So the exchange, remember, is for 138% to 400% of the federal poverty level, so that misses the folks at the bottom. The California Endowment has put up money to the state to actually offer a similar incentive to enroll people in Medi-Cal. As an agency, we're trying to explore what are some things that we can do to incentivize CBO partners to help us enroll people in Medi-Cal. So it's important to note, but the certified enrollment entity or counselors, it used to be called assisters. You might be hearing a lot about that, or people asking you questions. Navigators is a grant program to do outreach after open enrollment period to catch those populations that may be hard to enroll. So some of the local impacts, as I mentioned, so for social services, this is a huge change in business process. We have caseload caps, we have labor agreements, we have all of these exciting things that make it hard to navigate a huge bureaucracy in a time of change like this. It's a great opportunity to rethink how we do business, and it is roll up your sleeves time. So what we're trying to do is create this system of no wrong door to make sure that people who come into our offices can enroll in anything they're eligible for, and as I said, coordinate with other public benefits programs so that we're not losing families who may be eligible for CalFresh or CalWorks or some of the other benefits that we administer. I mentioned that we're taking calls from the Covered California call centers. What I didn't say is that the expectation from the state is that 80% of those calls are, the warm handoff happens within 30 seconds or less. Has anyone ever called a social services agency or even a state hotline and had a warm person talk to you within 30 seconds? This is a big change. It's great, right? So, but this is like part of what we're staffing up and training and getting people placed in their chairs. I mean, it's real logistics and nuts and bolts. We're going to be open extended hours and weekends, which is a new process for us. So just so you understand the volume, Alex already referred to it, we estimate 54,000 to 56,000 individuals will be coming through our doors. Some of these people were previously eligible but unenrolled. But the great thing about healthcare reform is that a lot of people are hearing about it, so a lot of people who were previously eligible are going to try to get enrolled. Okay, I'm almost done. So the timeline, big dates to remember, October 1st, that is open enrollment. That is when the pre-enrollment happens for people who are newly eligible for Medi-Cal, and it's open enrollment for the exchange. This is when everybody needs to be ready to get the word out, actually before this, but this is when it really starts. So while we know that healthcare reform really happens in 2014, for all of us in the field who are trying to get ready, October 1st is coming fast. January 1st is when, if you enroll during that window, your benefits kick in. So January 1st is when, you know, we're really excited that people will finally have the coverage that they deserve. Last slide or two, for more information, so Alex gave the Alameda County Consumer website. You should also check out the Covered California website. They have interesting information there, good policy documents. And then we've included the information on the certified enrollment entities for those of you or community partners who would be interested in becoming those. And then healthcare services and social services are hosting forums throughout the county over the next several months to make sure primarily that a CBO audience understands opportunities. So we've got save the dates up here. There's one coming up in September in Preservation Park just down the road. So that's it. And I just wanted to, my contact information is here. Gabriella's contact information, she knows more about healthcare reform than maybe even Alex. And then Cal Choi's information is here too, and he really is a great contact for the Medi-Cal outreach. So thank you.
Thank you. Any questions or comments from members?
I have a question of
Please use the mic.
Alex. And I'm particularly interested in the comment you made about establishing some sort of medical area in the fire stations. Are you working with Alameda County Fire on that?
Yeah, right now our pilot is in Hayward.
Is that in a fire station?
Yes. So basically
Expand a little on that.
the same business model that we showed you we've been developing around schools and community colleges and day labor centers. We think the same business model works with fire stations. The basic premise is ask in a marginalized community, poor communities of color, ask what public infrastructure do you know of? And after schools, the next most common response is a fire station. And so fire stations have a geographic distribution by housing starts by law. And what's happened over the last 20 years, as building codes have gotten better, sprinkler systems have been installed, fewer and fewer fires. But you as taxpayers are paying the same tax increment as always. And so what's happened is this, what's called a reverse subsidy system, where almost in all fire departments, including Emeryville, well, now Oakland, respond to 911 calls, get there first, but don't transport. So only, it's called a 201 right, but only 4 jurisdictions still transport: Piedmont, Albany, City of Alameda, and Berkeley. And the reason those 4 jurisdictions still transport is there's enough commercially insured people in those 4 jurisdictions that the fire department can make enough money by transporting them. Everywhere else, the fire department just gets there first and stops the clock for the private company that comes under contract to me. So now, if you're a firefighter, don't even bother applying if you're not an EMT or paramedic. In fact, some fire divisions are becoming exclusively paramedic. And it's because the future for fire is in health services. Transport, interfacility transport, EMS, 911 response, and less in fire suppression. And the challenge for all of us public servants is you got to have fire. They're going to be there. Whether they go once or 20 times a day to a fire, you need that infrastructure. No one argues that you should pay for it. The question is, can it be repurposed to be an asset in a healthcare system where costs are rising at 5 times the rate of wages?
That's a wonderful idea. I'd like to see that put on the Public Safety Committee for October, see if we can get some involvement with Alameda County Fire. Thank you, Alex. Grand idea.
Thank you.
Well, I just wanted to thank Alex and Lisa for coming tonight. And I don't know if you all know, Alex is actually the director of the Health Care Service Agency for the county, and Lisa is the policy director for social services. I heard this presentation about a month or so, maybe a little bit longer. And when I heard it, I just felt compelled to have them to come speak to this committee. And I think, as Alex kind of alluded to earlier, you know, Emeryville, you think of Emeryville, you think of, you know, this big bucket of money that's here, and everyone who lives here, you know, is well off and wealthy. But the truth of the matter is that we have in our school district 74% of our families are on free and reduced lunch. We have 2 major public housing development in Emeryville, and we have a nonprofit here, ECAP, that serves low income in the 94608 area code almost daily, distributing out food. So when I heard the presentation, I thought about where I sit as a public official. You know, I just felt compelled to have them come and to allow the committee to hear this in hopes that we as a committee could help do something regarding the outreach of those in our community, in our surrounding areas who would be eligible. So, you know, and we also have a family resource center that needs to be strengthened, and we need to continue to build collaboration around that center, so when ECCL does get built, our school health center would be robust. And I want to say, and when I think about this, you know, in its totality, my colleague over here, Mr. Simon, has been saying, I've been on the board for 8 years, and I think since that time, he's always said that ECCL is not about a building, it's about programs. And I think this is the catalyst for starting, as we heard earlier from one of our residents saying, you know, well, when are we going to have some type of, you know, medical facilities whereas our residents can come and be served. And personally, I believe that this is one of the greatest starts that we can start off with, seeing that we have the residents that are eligible, and as a district, we have a family resource center that we need to strengthen and we need to build our partners with. So with that being said, you know, if I could get the support of this committee to somehow get the school staff, the city staff, and this city school committee to form a task force that can collaborate with the county and, you know, see what can we do in this community. Maybe it's being a community-based partner. Maybe it is, you know, becoming a certified enrollment center. But, you know, as a public official, you know, I feel called to help those in this community who are underserved, and who needs the accessibility to health care. So I'll put that out there for the committee to discuss, chew on, or there needs to be a motion, I'll make the motion.
I'll just take just some clarification of Member Dwin's proposal, and first of all, I want to thank Alameda County and Lisa and Alex and the team for your great work, and I think finding a way to unplug the link between our address and our health is a critical piece of having an equitable community. And thank you, Member Dwin, for inviting you to come. This is the clearest answer that I've heard so far to the question that a number of people have asked about how are we paying for health care at the Center for Community Life. This is how we're paying for it, and I think being one of the 29 clinics in schools, having a clinic in our school is going to be critical. I did want to suggest that back to school night and school open house are the 2 times every year that at every school everybody shows up. So it's the biggest opportunity. If the folks from the Resource Center, Juliet, could come and have an enrollment table on those 2 nights, that's when all the parents are there. And so that would be great. Going back to Member Dwin's proposal, it sounds like, to the degree that we have Alameda County already working with the Wellness Center, that we already have a school clinic, and now Councilmember Davis has suggested putting on the Public Safety Committee this idea of a clinic for
Fire station on
the
Ball.
fire station, that sort of covers the 3 main topics. So I would want clarification from Lisa and Alex if there's sort of further action items we should be pursuing, and then maybe we can shape the committee to the purpose, because
Sure.
I believe in the Meeting Reduction Act.
So I've got one idea, and I don't know if it's an immediate idea just because of, frankly, our capacity with the rollout of healthcare reform, but Social Services Agency, in partnership with Healthcare Services, actually recently got a federal Connecting Kids to Coverage grant. And we have a partnership with Oakland Unified School District, Hayward Unified, and San Leandro Unified as part of Alex's team's Centers for Healthy Schools and Communities to work on eligibility, enrollment, and retention for children who have high rates of falling off of coverage. And one of the pieces to think about is, for example, right now with Oakland Unified, we're doing a data match for all the children who are on free and reduced school lunch, and the staff at Oakland Unified are doing outreach to those families before they fall off of coverage when their retention comes up, to make sure that they've turned in their paperwork and that they've got all the information. So there's things that we can do on a bigger scale with kind of data, looking at the data analysis, trying to think about how we use schools as portals for outreach, making sure that families maintain the coverage that they're eligible for. There might be a longer term conversation, but I would encourage you to think about how you might use your infrastructure as a school district to help families maintain the benefits or get the benefits that they may be eligible for.
So to address Member Dwin's suggestion, it sounds that this is more of a staff level work to look at how can, is there funding, for example, to work with our statistics with the Wellness Center and with the looking at our free and reduced lunch data, and we're one of the few school districts around that actually has a school nurse, thanks to our bond money. So are there ways that staff can work on this and then report back to us maybe sometime? I found your of all the presentations we've had, I've found your presentation the most clarifying and the most prompting of immediate action. So if you could help us to pick when would be the next most effective to come back with the results of your conversation with staff, because we can set all the direction we want, but at the end of the day, staff has to have the time and bandwidth and funding to do the work.
Well, let's hear from Juliet, because, you know, my proposal really is to outreach more beyond the school. Like I said, we have 2 large public housing developments. We have a nonprofit ECAP that serves in the 94608 area code. So let's hear from Juliet, and, you know, let's see what she feels staff, you know, is capable of, and then let's talk about it in its totality.
First of all, thank you very much for coming. It's something that we've been looking at and trying to figure out how we're going to give this kind of information to the people that we serve. One of the reasons that we started working with social services is because we had so many students and families drop off of Medi-Cal, and we couldn't figure out how to get them back on, just to get them basic services like glasses and medical. So we have the first Tuesday of every month at the Family Resource Center an intake worker who actually comes in and works with people who are on Medi-Cal. So that's already happening. The other part of it is that we do want to be part of the group of folks who can talk about the insurance and bringing it to as many people as possible. And it's not just students and families. The Family Resource Center is there to help students and families, but it's also to help community. And we have community members coming in from the rec center and seniors. We've worked with seniors, so we have a bandwidth of contacting and touching a lot of people. The first week in October, we're really trying to work on advertising the Family Resource Center. So I'll be in touch with both of you, because we would like to have this kind of presentation ongoing for people to come in. We'd like to, September 12th, with Annie Yates, when the parents are there, make this kind of presentation. I'll contact you. We can talk about shortening it so that we can have it both in English, in Spanish, and in other, so that we can contact people and let them know what their rights are, because we get questions and we don't know. We want to be trained. We want to sign up. We want to do that, but we have those forms already, and then move from there to see what we can do for the rest of the year to get us to the place where we contact as many people as possible and we have the information out there. So those are some of the things that we are doing that already are in works for other services that we could just add you on to. So we appreciate the introduction, and we are working with some of your services now through Alameda County Mental Health and Behavioral Health. So, hey, join the group.
And, you know, also, I mean, I would also like to include the city in this venture as well, in this effort as well. So, Cindy, I would ask you, you know, how could the community service department get involved in this in effort as well?
So we're the ones who refer people to Juliet's Family Resource Center from both the senior center and the rec center.
Right.
So we sort of
We are
doing that.
organically doing that now. We could do it a little bit more formally, but that's where we get a lot of our information from, those types of services that come in.
So do we feel sitting down with the county and kind of seeing how we could...
Speak to the mic, please.
I'm sorry. We will sit down with the county. We'll organize a meeting. We'll talk about what we do now, how we can increase that and increase the opportunity for us to affect folks. But I was just giving you an idea of some of the things we're doing right now, and definitely we can increase that. It's just, you know, making sure. It's nice to meet the people who you can now have. I have their cards. I'm going to call them. We'll talk about it. Cindy and I will talk. Wanda Hundley, who's our director for the Family Resource Center, will talk. We'll set up some meetings and we'll go through it. But just the presentation itself was very clear, which is nice, because it's very hard to explain a very complex subject and do it succinctly so that people will understand, oh, this is where I'm supposed to go, this is where I'm supposed to go, these are my choices.
So, okay, so that's fine. If staff is willing to take this on, that's beautiful. But I tell you, I'm very passionate about this, so I would like for staff to come back with an update November, December, based on the conversation that you've had with the county, and give us how the outreach process will happen.
Not a problem.
Thank you.
And we will be calling you to help us too.
Right, I'm proud. And don't forget the ECAP as well.
Oh, no, and I won't forget.
I fully support what you're saying, Miguel, and I think this whole issue of the health and the Family Resource Center and the clinics doesn't just impact the school district, it impacts the entire community. And I would like to see not just a report back in October, November, December, but I'd like to see a standing item on the agenda. This is a critical program in the ECCL, and we should keep a track on it every month. Brief, you know, we're talking 5-10 minutes. We're not talking bunches of paper. But it's critical to keep the policymakers' eyes on what is happening. Are there any glitches? Do they need more support? That type of thing. Would I have the support of the city school committee on that?
Yes, you do.
Member West?
Yeah, I think that's a great idea, but I would also honor a written report, so it's in our agenda packet, and doesn't mean someone has to give up their evening necessarily for a 3 or 4 minute presentation, but having it written ahead of time, then it gets to all the public. That'd be great.
And I think Member Dwin's point of not just including city and school, but to the extent we can do some outreach to groups like ECAP, as you've mentioned, or to, I don't know if Age Song is involved in this, but other groups, the Bread Project, we have a number of groups that serve populations that may have insurance issues. And it might be worth touching base with the chamber as well, because I think there's going to be issues that I think the requirement for businesses to have the insurance starts, in another year, in 2015. So I think having them in the conversation, it's good for people to be able to do their budgeting and planning to do that as well.
Thank you, Miguel.
Thank you.
My question for Alex and Lisa is, can schools staff, or the school would be the entity, I guess, be a certified enrollment entity, and could our family resource staff qualify for, basically, can we want to enroll people. If we can do it and make, some money while we're doing it, particularly if the endowment comes forward with a grant for the Medi-Cal enrollment aspect of it, is that something we can do, and how involved is it to become certified?
So first, you can become one. You can go on to the Cal Here's website right now and sign up. And you get, I think, $58 an approved application. The Medi-Cal side is more complicated. And in the sort of 3 realms I heard discussed, schools, communities, and the business sector, your collaboration between schools and healthcare is excellent in Emeryville. We have a long, strong tradition. The development of the Wellness Center is a good example of it. But school districts are facing some significant pressure because historically they've claimed this thing called LEA Medi-Cal, and currently claims are being withheld because of a long fight between the feds and local jurisdictions. And that's, in theory, a claiming mechanism school districts already have for helping kids get on Medi-Cal. So while you can look at opportunities for that exchange population, it's only going to be 25 or 30% of your kids. And I think chasing that money, I can't in good conscience recommend it, that there's a high enough volume. I'm just talking about the school box, because I heard these 3 boxes, right? Schools, community, business sector. So in the school world, I think it's more beneficial for you to continue what is frankly a pretty mature collaborative relationship between the district, social services, who's already in your center doing some enrollment eligibility, and us at the Center for Healthy Schools. There are revenue opportunities, not only in LEA Medi-Cal, but also in your new mandate under the IDEA for mental health services. Under AB 3632, it used to be the county. Under education-related mental health services, ERMS, it's now you. So you have a huge financial exposure if you don't get mentally ill kids on Medi-Cal, because you pay if they aren't on. So there's some new policy drivers that I think, to your point, there's work that could be done by school staff that will generate revenue and to help you avoid cost. And I think that's something we should be focused on.
So can we include that in part of the conversations, Ms. Dunn, that you'll be having with the county folks? That'd be great. Thank you.
Thank you.
Any public comment on this item?
Thank you for a great presentation.
Yes, thank you. All right, now we're going to